Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue the series I began last week on cancer of the stomach. Cancer of the stomach is a very, very common cancer, which is really very difficult to treat as well. According to the American Cancer Society, this year, 28,000 individuals in this country will be diagnosed with cancer of the stomach. And of that number, 10,960 individuals will die of cancer of the stomach. Now, worldwide, according to the WHO, uh, 750,000 folks will be diagnosed with cancer of the stomach, and 736,000 will die of cancer of the stomach. So the cure rate is extremely low. Now, as I mentioned last week, there are many risk factors for cancer of the stomach, including, of course, genetics, environmental factors, smoke, fish, pickles, processed food, H. pylori infection, smoking, alcohol abuse, obesity, etc. The symptoms, of course, include recurrent indigestion, acidity slash heartburn, recurrent nausea and vomiting, diarrhea, constipation, bloating, upper stomach pain, weight loss, anemia, poor appetite, fatigue, vomiting blood, black tarry stool. Now, I want to take a moment to talk a little bit about the vomiting of blood issue. This condition called hematemesis. Uh, Nowadays, pretty soon, the whole concept of how we teach medical students, intern and resident, and how we practice medicine in this country will hopefully change. An article came out in the New England of Medicine a couple of weeks ago, and I copied it so I can uh, show it to the students when I start teaching in October. It's going to switch over to case-based and evidence-based type of teaching, which is something that I and others have been preaching on this show and in other venues for years and years and years. And now people are realizing that this is really the way to go. I say this to say that the number one country in the world where there is more vomiting of blood slash hematemesis, not to say anything negative about anybody's country, happens to be China. And the reason for that, of course, is because of consumption of contaminated raw fish and other fish product, resulting in infestation of Chinese fluke, which then wind up in the liver, resulting in portal hypertension and esophageal varices and vomiting blood. So when one sees someone is vomiting blood, it's not necessarily because of cancer of the stomach. Far from it. Ulcer of the stomach is a common problem. That's why you check for H. pylori infection, because the number one cause of ulcer of the stomach is infection of associated with H. pylori across the world, etc. And of course, when I mention the need to know somebody's iron state in order to very early diagnose cancer of the GI tract, and in this case, cancer of the stomach, is really crucial. We're living in a world now where people are traveling back and forth from developing countries, visiting family or visiting themselves, etc., and they're coming back to developed countries such as the U.S. It is very important when you're evaluating them in the medical office to ask them, number one, where have you traveled recently? What country are you from? Very, very, very important, because if you travel from countries where you wind up being exposed to less parasite other than the Chinese flu, because Chinese flu is a parasite, but it's worldwide, you can be infested with with parasitic infestation, and then that then can lead you to losing blood, either by vomiting the blood and or by passing the blood slowly into your stool, resulting in iron loss. The confusion that I see that's creating the problem, or the lack of knowledge of this, is because a lot of folks, when they learn medicine, and they're very good, excellent doctors, unfortunately these concepts were not being taught. I know it wasn't taught to me, and I went to one of the best medical schools in the world, Albert Einstein College of Medicine, and this is stuff that I had to learn myself, namely anemia associated with iron deficiency is the last stage in the iron deficient syndrome. Iron deficiency syndrome is not the same as iron deficiency anemia. This book has a chapter in iron deficiency and a whole host of other different type of anemias. And in that book, I outlined the 4 different types, the 4 different stages of iron deficiency state that then ultimately lead to iron deficiency anemia. So if you understand those 4 steps, you realize that your patient who comes to you for either a so-called annual physical, which really doesn't exist anymore because the HMOs basically that they don't pay for annual physical, but the patient comes to see you for an evaluation for one reason or another. And then you decide to check the patient's blood count, you decide to check the patient's iron level by way of doing either the old-fashioned iron level or the ferritin, which I prefer. Then your patient is not anemic. The hematocrit is perfectly normal. A normal hematocrit is 36 to 42 percent in a woman, and 42 to 50 in a man. So, and the serum ferritin is 10 through 290 or so in a woman, and 10 to 320 in a man, in a normal sized man. So if you understand iron kinetic, you understand that the ferritin is a range. So if the patient has absolutely no other reason why she's not a menstruating female, because all menstruating female and all female who've given birth suffer from iron deficiency. I didn't say iron deficiency anemia, but you can be a menstruating female and female who have given multiple birth and don't have iron deficiency. You suffer from iron deficiency syndrome, which is not the same as iron deficiency anemia. The anemia is the last step in that syndrome. So the best way to really do this and to help somebody that is really in need of help in terms of discovering the place where they're losing the blood, putting aside the childbirth and the menstruation, we know about that, and I've gotten to that, I'll get into it again, is the fact that there's no reason whatsoever for a man who's not urinating blood, who's not having hematemesis because you could see it, who's not coughing up blood either, to suddenly have low serum ferritin, or a ferritin that is, let's say, 100 for the sake of argument. It should be 320, it's 100. You just can't take that and file that away and tell the patient he's okay, because he's not okay. His blood sugar may be normal, his cholesterol may be normal, all his electrolyte may be fine, his thyroid profile may be fine, but you can't say he's okay if the ferritin that's supposed to be 320 is 100. That is the time when this patient needs you the most, believe me, even though his hematocrit is 50, which is the high normal, because you must explain where is the blood loss is coming from, because blood loss equals iron loss. Every cc of blood has 0.5 milligram of iron in it. And as I mentioned last week, and I'll repeat it again, a normal-sized man has 2 grams of iron in his circulation and 1.5 gram of iron in the store. That 1.5 gram of iron is the equivalent of 6 units of blood. Unit of blood is the bag of blood that's taken from you when you donate blood. And the 2 grams of iron that's in the circulation represent 8 units of blood. So if the ferritin is 100 and it's supposed to be 320, that tells you that individual, this man, is losing iron very slowly. Because when you are bleeding slowly, chronically, the first iron you lose is the iron in the circulation. That's right, it's the iron in the circulation. I'm sorry, the iron in the store. That's the first iron you lose, is the iron in the store, which is manifested as ferritin. So by knowing that the ferritin is down, then you begin the investigation right there and then. This is the time, the most appropriate time that you could do the most for this patient, to send him to the gastroenterologist to find out, to do a complete GI evaluation to see where is the ferritin loss is taking place. 100% of the time, 100% of the time, the GI doctor will be able to tell you. They can do from the esophagus down to the stomach. They now have many gastroenterologists who are very proficient at getting into the small bowel via scoping the small bowel as well, and they can do colonoscopy. Those who are not able to scope the small bowel, there is a capsule study that they can do looking for other pathologies. And the pathologies can range from a polyps that's bleeding, an AVM that's bleeding intermittently, an ulcer in the stomach, or cancer in the small bowel, or what have you, okay? Or something in the esophagus, something in the rectum. It doesn't matter. They'll be able to find it. So that's how one goes about practicing medicine most effectively, in this case, GI medicine as it relates to GI bleeding. In a female, it's much more complicated. It's much more complicated because a normal menstrual period that is not having anything to do with excessive menstrual bleed, the woman loses 50 cc's of blood, and half of that is iron, 25 milligrams of iron, okay? So by knowing that, you can go back, you can go right back and find out, number one, at what age did she start menstruating as a young girl, 9, 10, 11, or whatever, and you could trace that back. Then, if the lady has had children, for each childbirth that carries to term, by necessity, she must lose 750 milligrams of iron. That is correct. 750 milligrams of iron is taken away from the mother by the fetus during each pregnancy that goes to term. So she's got 4 children. Well, you could calculate that 750 times 4, that she lost that iron. And then she's also losing blood after the appropriate time, after she gives birth. On top of that, if she's breastfeeding, she loses blood from that, iron from that as well. So all those things can be calculated. I'm not very good at math, but even I can sit down and calculate that. And then when you put that together, then you know what you expect her ferritin to be. That's right. I'm not going to sit here and detail for you all the stuff that I know and how you could figure it out. That's not the purpose of this. This is just an introduction. But believe me, I know how to figure this out. So this gives you an idea how you expect her hematocrit to be. If the hematocrit is expected to be 36 to 42, then now you're dealing with a hematocrit of 30, then you got to figure it out. Yeah, and then by looking at that sheet that's given to you from the lab that goes to the computer, you could, at the bedside, at a glance in your office, in the palm of your hand, you hold it, you could eliminate a whole host of other causes of anemia. That's right, at a glance. That's called hematology at a glance. I'm not going to tell you how to do all this stuff, but you could just look at the sheet, look at the just look at the indices. The indices are the MCV, the MCA, and this kind of stuff. You look at that right away. You look at the red cell per million, and look at the percent of hematocrit. I say I wasn't going to tell you, but I'm giving you a hint. Right away, by knowing certain things, certain formula, you could figure out if the person, man or woman, have other causes to that causing the anemia. Let me give you a hint, okay? I said I wasn't going to do it, but I'll give you a hint because it's not fair to the students who are watching the show. I say I'm not good in math, which I'm not, but what I can tell you, for every 10% of the hematocrit, write this down, for every 10% of an individual hematocrit is equal to 1 million of the red blood cell. Let me repeat that. Every 10% of a human being hematocrit is equal to 1 million of the red blood cell. So therefore, if the red blood cell per million is in excess of the percentage of hematocrit, at a glance, you know right away you've got a whole host of other medical problems having to do with thalassemias, etc., taking place right there, hemoglobin C, etc. I mean, it's at a glance. This is why when the students come to my office, I tell them, you are going to be given a hematology course in medical school. I think it's given in the second year. But in the first week in my office, you're already getting that course right there. So when that course is given to you, you're going to be able, you will be way ahead of the game, way ahead of the game. And if the percent, if there's a discordance of 500,000 or greater, then you have erythrocytosis that doesn't exist there. It doesn't belong there. The percent, the red blood cell per million is much higher than the percent hematocrit. And right there, if you do a quantitative, not qualitative, quantitative hemoglobin electrophoresis, you could pick up all the abnormal hemoglobin that can cause that erythrocytosis with microcytosis, okay? That's crucial because if we're talking about iron deficiency, which we are, which can then help us to diagnose iron deficiency anemia, then you look at the MCV is going to be low. It's going to be low. But if you were born with if you were born with any one of the thalassemias or hemoglobin C, for the rest of your life, you're always going to have low MCV, always. That's the way you were born. So you can't just hang up on the MCV all the time. You have to practice case-based medicine because the person may have folate deficiency. The person may have B12 deficiency. The person may be hemolyzing. And even that, there will never be a high MCV. There'll never be macrocytosis, MA, in this individual. You understand that? So if you understand who is the person, where the person comes from, what's the ethnicity of the person, then right away you could still diagnose B12 deficiency. You could still diagnose folate deficiency because you will have ordered these tests, because you will know you have erythrocytosis with microcytosis, and you know the patient is not hemolyzing. There's a way of telling that as well. I mean, I can go on and tell you why these things can turn you into a clinical star, if you will, if you understand these things. So therefore then, to diagnose cancer of the stomach early, at its earliest possible stage, so that you could give the patient the best chance to save his or her life, is by knowing these things years ahead of time, 2-3 years ahead. You're going to pick up that abnormality, and when the scoping is done, whatever the process or processes that's causing the cancer to develop inside the stomach, the GI doctor would have taken it out right there through the scope. They're going to take it out right from the scope, right there, and send it to the lab to be evaluated by the pathologist, okay? So, now then, we get to the point, now that I've given you the spiel, we could talk to them about what do you do? Well, as I just stated to you, you will take the history, you'll do a complete physical exam, you'll do a blood count, you'll do the ferritin, you'll do the total chemistry profile, you will test the stool for blood, yes. And in certain instances, as you look at that differential count, you may see the patient has eosinophilia. Well, the eosinophilia, that patient has no business having elevated eosinophil. If he or she does, right away, you know the person probably is infested with parasite. Yeah, there are other things that can give you, but I'm talking about blood loss, chronic blood loss, and elevated eosinophil. When you look at the differential, right away you send the stool to the lab to be evaluated for parasite. That will eliminate a whole bunch of other. Can you have parasite and cancer of the stomach at the same time? Yes, you can. But this is why it takes brain power to practice clinical medicine. You can't just practice it using the lab. You have to use judgment. You have to use judgment. You don't miss people's diagnoses, and then which can lead to them getting hurt, which almost happened to me 3 separate times. 3 separate times I used this thing that I'm talking to you about to save my own life. 3 separate times, I had 3 separate cancer. Each time I said I didn't have cancer. I know I did, because I know the stuff. I knew. I did my own blood count. I knew something was wrong, so I insisted that I get evaluated further, or if in that matter, I evaluated myself further. I ordered my own CAT scan, my own MRI. I did all that. I even ordered my own PET scan at one time that picked up one of the cancers that I was told I didn't have. Because I knew not only that I had the symptom, but I had the result of the blood test in my hand that everybody tested were normal. They were not normal. They were normal for those people who don't understand what they're talking about, but not for me. And I saved my life. And here, I'm sitting here talking to you, alive and well and doing very well. So the things that I'm taking, they are valuable if you understand. If you don't understand them, please send the patient to people who understand them. Don't send them to me. I'm not seeing new patients. People are calling my office every day, multiple times. Do not call my office. I'm not seeing new patients. I have enough patients to keep me busy. I'm not taking new patients. Don't call my office. So now, we diagnose cancer of the stomach. What do we do? Okay, well, the pathologist says it's cancer. Then you wind up having to now do the clinical staging. Part of the clinical staging would include doing a CEA, doing a PET scan. PET scan is crucial. You don't have to be a whole host. If you don't have access to PET scan, you wind up doing CAT scan, blah, 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 looking for metastatic disease, etc. But if you do PET scan, again, as I mentioned before, the PET scan is a bit expensive, and you have to fight with the HMOs for them to pay for it. But if you get a chance to speak to a reasonable doctor at the other end of the line, he or she might approve it for you. And the PET scan is a test during which a molecule of glucose is tagged with a nuclear tracer, and is going to be infused into the patient's vein, and the patient is asked to stay very quiet, because each time you move a muscle, you use sugar. And all cancer cells, no matter what type of cancer, love sugar. So they're going to grab into the glucose, incorporate it into the nuclei, and then there's a tracer. So therefore, a couple of hours later, they will scan the patient, and wherever there's cancer that's growing, it's going to light up on the scan. That's how you know whether you have metastatic disease or not. Okay? So that then allows you to make a decision how to proceed. You're not going to remove cancer of the stomach in a patient that already metastasized to the liver or to the lungs. You're not going to do that. You may wind up treating the patient with chemotherapy, radiotherapy, etc. But why bother doing the surgery unless the patient is obstructing or something? Then the GI doctor may want to do something to prevent the obstruction. But the patient already metastasized. Cancer is diagnosed stage 1 through stage 4. By the time it's already reached into the liver, it has already metastasized. By the time it reaches in the lung, it's already metastasized. Okay, and the PET scan will light up in the lung. It will light up in the liver as well. So now, how do we go about treating cancer of the stomach? Well, you have surgical resection, chemotherapy, and then so this is really on the list of chemotherapeutic agents that are out there. You have 5-FU, cisplatin, epirubicin, docetaxel, etc. All these things are used in combination to treat the cancer of the stomach. And recently, the FDA approved something called Simraza for advanced cancer of the stomach. It is a very, very difficult cancer to treat. Let me show you if you could see that. This is a PET scan. That little light you see there, that's the metastatic disease that's cancer of the stomach. This is a PET scan. Okay, I don't know if you could see that, that little yellow thing that you're looking at, that's the cancer in the patient's stomach, okay? So, and that's how you go about it. It's a very difficult cancer. You have to practice clinical medicine by infusing the patient with blood when it is necessary, by treating the patient with antibiotic when his or blood cell drop, etc. It is tough. A lot of the time, the patient dies not because of the cancer, but it's because of the complication of the cancer, such as infection is the number one complication, blood loss, so on and so forth. And it is tough. It is tough to see patients, and I've lost several patients. I've only cured 2 patients of cancer of the stomach in my 44 years that I've been practicing medicine total, almost 40 years as a private physician, only 2. Only 2. It is very difficult, and most doctors will tell you the same thing. So the key thing is to be careful, watch your diet, cut down on alcohol consumption, give up the cigarette, control your weight, and hopefully you will have the good genetics that will help you, and your doctor will be able to pick it up early enough by knowing some of the stuff that I talk about, which can save your life. Listen, I'm stopping here. Until I see you again, this is Dr. Alcena saying so long and bye-bye.